Alrighty, welcome back to the Advanced EMT. Of course, we're using the Pearson's Advanced EMT, a clinical reasoning approach, second edition, the updated version. Chapter 10, Pathophysiology. We're going to talk about select impairments of the homeostasis. So we're talking about homeostasis and everything that affects it. All right. So what is homeostasis? It's the psychological steady state achieved by the body's complex regulatory mechanism. So it's that the body wanting to be in that neutral buoyancy or position, right? So it works for this homeostasis. Now, there's several things that can disrupt homeostasis. It could be a disease, environmental conditions, traumas. When this happens, the body's going to respond, try to correct it and getting back into this homeostasis. They'll respond, but they're not always effective. Signs and symptoms will appear, but they may be superficial indications. An EMT must recognize the signs and symptoms and understand the cause. They want you to know the definition of these terms. Physiology is the study of the function of the body. Pathology is the study of disease. And pathophysiology is the study of the effects and processes of disease and injury. Just note that all diseases and injuries will affect the body at the cellular level, and the body response will respond in a predictable way to specific threats to that homeostasis. Talking about that, mechanism of disease and injury. The mechanism of homeostasis can be disrupted in several ways, and these are the ways right here. We got hypoxia, nutritional imbalance, genetic disease, cancer, physical injury, toxins, and infections. This is in your book. This is chart 10.1. This is a pretty good little chart. It breaks down these mechanisms like hypoxia. It can be from like an opioid overdose, which will in turn depress the respiratory centers in your brain. Nutritional imbalance. This is an example they give is a patient who is diabetic, takes their insulin but doesn't eat. Physical trauma. Patient falls from roof. When he lands, a screwdriver is in his tool belt and impels him on the right side, lacerating his liver. The liver begins to bleed, and you'll go into a shocky state. Infection. They say a patient gets pneumonia. These are all examples. There's multiple examples, but these are the ones they're using. Toxins. They can get CO2 poisoning or carbon dioxide poisoning if a faulty furnace or something that's got combustion and it's not vented properly. And environmental. A hiker becomes lost in the mountain trail late in the day, sweats their clothes, they evaporate, heat loss, they get hypothermic. We have different categories of mechanisms that they use in the book. The hypoxic cellular injury, shock, impaired glucose metabolism, electrolyte and pH disturbance, environmental disorders. And remember that they may have overlapping or multiple mechanisms, right? You could be hypoxic from the shock, which could cause shock. You could have electric imbalance. They can just all overlap. Remember the body's capability of remarkable adaptation under the stress. They can withstand significant challenges to the homeostasis. However, long term, the cells will adapt to a variety of conditions. Here are some types of cellular adaptations. Sorry. These are all in your book. You need to read through these. Let's go into hypoxic cellular injury. Ischemia, this is lack of blood flow, which results in hypoxia. Can be reversed if we restore perfusion or if we ventilate and with supplemental oxygen. They will initially the cells will adapt by going from aerobic to anaerobic metabolism, but this can only last for a very limited time depending on the cells. Some cells, they can go a lot longer, but some of your cells are very limited that they can run on this anaerobic metabolism. Some of those cells will be like your brain cells, your heart muscle. They need to be in the aerobic metabolism. Hypoxic cell injury occurs anytime oxygen to the cells is disrupted. This can be several reasons, and we're going to go into that a little bit. So, in order to make ATP, we've talked about that in the other chapters. It's glucose is broke down and it's combined with oxygen, which turns into ATP and what is that? Adenosine triphosphate, which is made in the mitochondria in the cell. Without the ATP, the cells can't work. They don't have any energy. Let's talk about the difference between aerobic and anaerobic metabolism. The anaerobic breaks down the breakdown of oxygen glucose to produce large amounts of ATP or energy. When the lack of oxygen for some reason, you go into anaerobic, and they start producing ATP, very limited ATP without the oxygen, which means the cell can't function. And then you start building up of like byproducts like lactic acid. We need adequate oxygen delivery. So this means we have to have adequate unloading of oxygen in the hemoglobin. This hemoglobin or oxygen-rich hemoglobin has to be circulated through the body. And we have to have adequate offloading to the tissues once they have reached the cellular structure. Hypoxic cellular can be disrupted in 4 ways. We can do the delivery system, the bloodstream, the transporting the oxygen through the bloodstream, the transporting of oxygen from the bloodstream to the cells, and the oxygen actually being used by the cell. Remember, there's 21% in oxygen in atmospheric air with 79% nitrogen. Patient must have proper ventilations to produce adequate tidal volume, minute volume. And the body will compensate for decreased tidal volume by increasing the respiratory rate. Makes sense, right? If we're not breathing enough, the respiratory rate's going to go up. Shallow breathing results in inadequate ventilation. Remember that the atmospheric pressure and partial pressure of oxygen will decrease in altitudes. And symptoms, altitude sickness can develop at elevations of over 8,000 feet. The airway must be unobstructed for oxygen to reach the alveoli. What could cause obstruction? Swelling from an infection, allergic reaction, trauma, loss of muscle tone, which would cause the tongue to relax and the throat muscle to relax, or foreign body in the airway. The respiratory center in the brain must function to stimulate inspiration and respiratory cycle. As we've talked in the past, this is in the medulla oblongata. This is in the brainstem. And there are things that can block the communication. So anything that blocks the communication between the nerve and respiratory system can lead to hypoxia, right? If we're not breathing properly or at all, we're going to get hypoxic. The alveoli, they must be close to capillaries for the oxygen to diffuse. So if we have stuff like pulmonary edema or pneumonia, this causes swelling, and this may make this harder for the diffusion to happen. Bronchial constrictions, such as in asthma, COPD, or anaphylaxis, this will result in the bronchi or the bronchioles constricting, so there's less air moving in and out. We have this thing called surfactant in our lungs. This is what keeps the alveoli open. It keeps them from sticking together. So to keep them open or expanded. We've talked about the VQ mix match before. So if we have a decrease in ventilation, lung perfusion, or both. So this is if we're not breathing enough, or our circulatory system's not working well enough to get the blood there for that exchange to happen. If underlying problems aren't corrected, respiratory failure occurs. Untreated, failure turns to respiratory arrest. And of course, respiratory arrest will lead to cardiac arrest and death if we don't fix it. So, how's the oxygen transported in the blood? There are things that can affect this, like anemia. This is the number of red blood cells that we have, so the number of hemoglobins are low. It's an iron issue, so we can't make new hemoglobins. Acidosis and alkalosis alter the ability of the oxygen to bind. So if our pH level is off, we won't. The oxygen has a harder time binding or staying bound to the hemoglobin. Cardiac arrest, of course, the heart stops beating, the oxygen can't be delivered, so we have no flow at that point. They want you to define each of the terms: CPR, SCA, defibrillation, CPR, cardiopulmonary resuscitation. SCA is sudden cardiac event or attack, and defibrillation. We all know what that is. Three different phases in cardiac arrest. We have the electrical phase, the circulatory phase, and the metabolic phase. They're all defined in your book. Patient survival often depends on these variables: immediate recognition of cardiac arrest, right? Immediate CPR with emphasis on compressions, rapid defibrillation, early advanced life support, and integrated post resuscitation management. So if you look at this is our chain of survival, right? Early recognition, early activation of EMS, good high quality CPR, rapid defibrillation, early advanced life support, and post care. These are all in our chain of survival in the AHA. Alkalotic states can be diminished the ability of hemoglobin to deliver oxygen to the tissues as needed. We talked about earlier how acidotic or alkalotic states can cause the hemoglobin to the oxygen not to bind to the hemoglobin, or for not to be able to stay bound, so it won't get to the cellular level. Cyanide is a substance that prevents cells from using oxygen. Anaerobic metabolism can occur. Cells switch to anaerobic. If untreated, cyanide poison rapidly causes death from asphyxia because it'll bind to the hemoglobin and won't let the oxygen bind to it. Through glycolysis, cells use glucose to produce ATP, that and oxygen, right? Briefly, some cells can adapt. So we talked about that a little earlier. Some cells can adapt to the anaerobic and last longer than other cells. We talked about the toxic byproduct of lactic acid. Cellular glucose. Insulin. We talked about this. It's the gatekeeper or the key holder. Glucose cannot enter the cell, so the insulin will facilitate this glucose passage across the cell membrane. And without insulin, glucose will remain in the blood. Without glucose, the cells will use different things for energy, different sources like fatty acids, ketones, and then this ends up becoming diabetic ketoacidosis or DKA if they're using the fatty acids, which breaks down into ketones. And then once we get an abundance of ketones, it turns into diabetic ketoacidosis. Normal glucose levels are 70 to 120. Influenced by insulin and glucagon, of course. Hypoglycemia is low blood sugar, of course. Symptomatic signs and symptoms, and it can have brain dysfunction. Here are signs and symptoms of the hypoglycemia. They have anxiety, sweat, tremors, extreme hunger, rapid heartbeat, irritability, uh, confusion, anger, weakness, blurred visions, slurred speech, poor coordination, seizures, or unresponsive coma. Talking about the acid, base, and electrolyte disturbances. What causes acidosis is hypoxia, DKA, toxicity with acid substance like aspirin, antifreeze solution. Now we're going to break it down into metabolic and respiratory acidosis. Metabolic acidosis, arterial pH of less than 7.35, and we have bicarbonate levels that are less than 24 milligrams of mercury. As the pH decreases, hemoglobins become less effective at binding to oxygen. So as we get more acidic, it's becoming harder for the oxygen to bind to the hemoglobin. Once this happens, the cell's not getting oxygen, so it forces in the anaerobic, which will produce less ATP, and in turn will produce lactic acid. And then this will in turn, this is how it worsens the acidosis, because now you got lactic acid. Metabolic alkalosis. This is antacids. We're taking too many antacids, so bicarbonate. We're vomiting. We're diuretic, so we're getting dehydrated. Signs and symptoms may vary, but hyperventilation can occur in severe cases. We may have an electrolyte abnormality, may be present. We need these electrolytes to maintain with a narrow range for normal cell function and fluid balance. A lot of our electrolyte function is the moving of water and proteins. With an electrolyte imbalance, we can have cardiac rhythm, we can have electrical conduction issues, the contractions can be affected. Moving on to shock, all forms of shock comes from a pathway indicating cellular perfusion to meet the metabolic needs. So the lack of cellular perfusion to meet the metabolic needs. Shock is an inadequate oxygen supply to meet the demand. Excuse me. The different forms of shock, we have hypovolemic, which is hypoperfusion from the loss of blood or fluid, right, level. It can be actual blood loss or loss of volume. And if we don't have enough blood, we can't carry enough oxygen, so our tissues can't be perfused. We go into different stages of shock. The compensated shock, which means our body has recognized something's wrong, so it's going to compensate for this. Heart rate's going to go up, respiratory rate's going to go up. Blood pressure should maintain close to normal or what it was prior. Then we go into decompensated shock, and how we can tell the difference between compensated and decompensated is our blood pressure is starting to drop. So our body's no longer able to compensate. So our blood pressure will start dropping. And if we don't fix the problem, it'll go into irreversible shock. And the key note is to tell the shift is when not only the blood pressure starts to drop, but so does the heart rate. Signs and symptoms, classic presentation of shock, right? Tachycardic early. We're going to get pale, cool, clammy skin. Respiratory rate's going to go up. We could have an altered mentation, including unresponsive. Remember, decreased blood pressure is a sign that we're moving from compensated to decompensated shock, so it's going to be a later sign. At the vascular level, hypovolemic shock, there's ischemic phase, stagnant phase, and washout phase. This all has to do with the blood and the capillaries. It's all in your book. Please go back and reference this. Hemorrhagic shock is a type of hypovolemic shock. This is specifically blood loss. We talked about the hypovolemic could be volume, so this could be dehydration, but hemorrhagic shock is due to blood loss. It may not be obvious because we could lose a lot of blood in our cavities, like our pelvic cavity or into our abdomen, chest cavity. They all can result in enough blood loss to result in shock. Here's the stages of hemorrhagic shock. Class 1. A class 1 hemorrhage is up to 15% of the total volume, which is usually tolerated and can lead to mild tachycardia. A class 2 is 15 to 30%. We'll get moderate tachycardia. We'll get pale skin, delayed cap refill. So we're starting to show that signs of compensated shock. Class 3 hemorrhage, 30 to 40% of loss, volume loss. Definitely have tachycardia, failure of compensation. So we're going to start to see that hypotension or that lower blood pressure. And a class 4 hemorrhage is 40 to 50%. This is profound hypotension and organ failure. For example, we're going to start to see the bradycardia, and eventually, if this isn't fixed, it is death. The next form of shock is cardiogenic. This is something to do with the heart or the pump. So the heart's not pumping sufficiently to maintain the cardiac output. This is mainly caused, one of the biggest causes is an MI or myocardial infarction. Signs and symptoms, they'll be anxious, they'll have pale diaphoretic skin, chest pain, especially if it's due to an MI. We'll start to see maybe some pulmonary edema because the heart's not pumping, so it's going to backflow back into the lungs. And our heart rate could be either fast or slow. Pre-hospital treatment, we're going to support the airway, breathing, circulation. We're going to give medications for the myocardial infarct, electrolyte therapy, electrical therapy if need be, interventions to correct underlying causes. Now, the electrical therapies would be depend on what our rhythms are, and we'll go into that in the future. Remember, the mortality rate is pretty high with cardiogenic shock. If they got to that point where they're in cardiogenic shock, that means the pump is failing. The next category is disruptive shock. This would be the neurogenic, the anaphylactic septic shock. During disruptive shock, it's uncontrolled vasodilation. That means the container will be too large for the amount of blood, so our blood pressure is going to tank. Neurogenic shock, we lose sympathetic tone, uncontrolled vasodilation below the injury site. Can result in sudden onset of hypotension. Now, neurogenic shock is going to could present differently than any other shock because the skin can be warm, dry, and pink. The heart rate could be normal, and they may have possible impaired ventilation depending on where the injury site is. So just remember, they could be pink, warm, dry, have a normal heart rate, still be in shock. Pre-hospital care, we're going to spinal motion restriction, airway management. We're going to support ventilation if need be. Supplemental oxygen, keep the patient warm. IV fluids according to your protocol. So we're going to do all of our BLS skills, right? Immobilize, manage the airway, give them supplemental oxygen, keep them warm. And then the advanced side would be administering IV fluids, start an IV and give them fluids. Anaphylactic shock, severe allergic reaction, common causes, right? Food, environmental, like bees and wasps, medications like antibiotics, some pain medications like morphine, other drugs. Those are the big ones. Like food allergies and bee stings and medications. Those are all big cases we see in the field. Remember that it can progress very quickly, which means the patient could be dead in a few minutes. Signs and symptoms, we get that hive or that urticaria, especially hives in the chest. They have that itching in the throat, stridor, and wheezing because their airway is swelling. They could have abdominal cramping and airway swelling. Treatment, of course, we know the epinephrine and IV fluids, and then we're also going to give diphenhydramine or Benadryl. The difference is, and depending on the region, but in the region that we work out of, our EMTs are allowed to give Benadryl PO or by mouth, a tablet, whereas in advance, we'll be able to give it IV, which is going to work way better. We'll talk about the dosages and all that stuff later on, but we're actually talking about anaphylactic shock in this program. Sepsis or septic shock, it's a systematic inflammation response to a pathogen. Signs, we're definitely going to have a high fever. Can be absent in the elderly because they don't regulate as well. We'll have tachycardia, respiratory distress, decreased mental status, and hypotension. Pre-hospital treatment, we're going to manage the airway. We're going to ventilate if need be. We're going to watch for our cardiac rhythms. We may have to fix the circulation, and we're going to keep them warm. Obstructive shock is the last category. This is something that's physically obstructing the blood flow. Some of the causes are PE or pulmonary embolism, a tension pneumothorax, or a pericardial tamponade. Here's some pictures, like the pulmonary embolism. Here's a blockage in the blood supply to the lungs. Tension pneumo, of course, is going to put pressure on the heart, so it won't be able to pump. And same way with the pericardial tamponade. This is blood filling in that pericardial sac, or fluid filling in the pericardial, not letting the heart able to contract. Pathophysiology of shock. Regardless of the cause, the initial signs and symptoms of shock are externally manifestation of the body's compensating reaction to hypoperfusion. So the signs and symptoms are the body's way of compensating for that hypoperfusion, trying to get back into that homeostasis. As this progresses, the compensation or the compensatory mechanisms will fail. So our vital signs are going to reflect that. We talked about earlier, one of the first signs is our blood pressure is going to start to drop. Many signs and symptoms due to the release of epinephrine and norepinephrine. They're going to get very anxious, pale, cool, sweaty skin because they're going to vasoconstrict in the periphery. They'll get tachycardic, may have nausea, vomiting, thirst, decreased urine output, and increased respiratory rate. Your role is to anticipate and recognize shock quickly, provide the field interventions. Remember, going back to our BLS, position, oxygen, cover them up. And as they're advanced, we're going to cardiac monitor, IV, fluid replacement. Maybe intubate if need be. And we're going to provide to the closest facility to take care of this patient. Hot and cold emergencies. That hemostatic mechanism will keep our normal body core temperature around 98.6, and that can fluctuate. Some people run, like for example, myself, I run like 97.6, so that can fluctuate. Anaerobic metabolism reduces heat generating capabilities. The cells aren't functioning properly, so we lose that capability to produce heat. Negative feedback systems for hypothermic and hypothermic. If the mechanisms are overwhelmed, death can occur. Blood clotting mechanisms fail. CNS fails. All right, so the chapter summary. Disease and injuries often present as emergencies with pathophysiology results in inadequate cellular energy production to maintain cell function. Pre-hospital treatment. We're going to ensure delivery of oxygen and glucose to the cell and maintain normal body temperature. An advanced EMT provides general supportive treatment to maintain the patient's airway, breathing, circulation. You must understand the pathophysiology of the patient's problem. All right, so that will end it for this chapter. We will see you on chapter 11.